welcome you and move on from the welcome as quickly as we can so we open up as much time as possible today for your input, ideas, and feedback. So when we do these sessions, I know that you guys are taking time away from work, so I just ask that you put your cell phones on vibrate or silent if possible, and that would be great. And I'll have a reminder of other logistics in a minute for the room. So today my role and the role of WSU is really to help facilitate this feedback and input session with the Kansas Department of Health and Environment. So we want to make sure we're getting stakeholder questions, input, comments, and this, as you know, is the provider session. So today, what we're going to do is share comments out loud. You can write them down, you can email them in, and there are sheets on the table to show the email and address to do so if you need that, to do that in addition to what you comment today. And that is so that we can really make sure we're getting all of your input on this topic of the KanCare Renewal. So I want to take a minute to remind you that we are recording as well, so we're taking notes and recording as backup, so we do capture everything that is said here today, but again, in addition, you can always email and write in your public comments and feedback for those ideas you have. So I want to take a minute and introduce Dr. Mosier. She is the Secretary of the Kansas Department of Health and Environment, so KDHE. So if you want to come on up, I'm just going to give a few words and welcome.
Thank you, Jennifer. Just a couple of brief remarks before we get started. First, I want to thank you all very much for coming, and thank you. We greatly appreciate your input and feedback today. In looking back at KanCare 1.0, which we're 4.5 years into, when we looked at KanCare 1.0, we had a couple of things in particular that we were wanting to achieve. One was better coordination of care across behavioral health, physical health, long-term services, and supports. In addition, we really wanted to create a greater focus on prevention, wellness, earlier detection, and earlier intervention, and so that we would move up that healthcare spectrum from care to that greater emphasis on health and wellness. In KanCare 2.0, we want to improve on care coordination across the healthcare spectrum, but also expand into areas of social determinants of health, like transportation and food security. Today, we're going to be asking for additional input on value-based purchasing, or some of you may have heard of it as MACRA, or MIPS, or APM. MACRA stands for the Act, the Medicare and CHIP Reauthorization Act that was passed last year, and in that there's a movement from payment for volume to payment for value, and that can be achieved through alternative payment models, or APMs, or MIPS, which is Medicare Incentive Payment System. So we'll be asking for your input on that. Your input on how to streamline and reduce the administrative burden, and also on improving the effectiveness of training and better meeting your needs around training for Medicaid and CHIP. And any other ideas or input that you have. I do want to point out that we have several state staff here, and I'm not going to introduce everyone. I just want the state staff to raise their hands so you know where they are. If you have any questions, thank you very much. And then also managed care organization staff. If you have questions for any particular managed care organization, we have a few staff here as well. So thank you very much, and I'm going to turn it back over to Jennifer Pasek. Thank you.
Thank you. So just to talk a little bit about the format and kind of how this meeting will work, and I think that's always good to know our outline of how we can work together. So we're going to have KDHE present some information about the renewal process and how they're responding to the feedback that they've heard already. We will then have 3 rounds for comments, questions, and ideas, and feedback. 1 round for each of the specific topic areas mentioned by Dr. Mosier. So. And then when we have those rounds and they will introduce the topic, KDHE will move to comments and ideas. We will have WSU staff around with mics to gather that so you can use that. And then we will move on to the next. We will then have, at the end, a final open comment feedback input session for any other those that we didn't touch on. Okay. So just to go over some logistics for the room and where we're at. There are refreshments in the back to the right, coffee and water. Restrooms are out the door to the left. And I want to just, so you know who to turn to from our staff from WSU to help you, I want to introduce them. So we have Bill Mason. He is our room host. So if you have any room needs or concerns, please see him. Okay. We have Vincetta Baker. He's taking notes, but again, we are recording, so that's always good, so we know we can capture everything. And then I have Lindsay Stillwell and Seth Bates will be coming around table to table with the mics. And so when we go through the rounds, we'll give some more direction on how we're moving through the tables at that time. So right now, I'd like to introduce Mike Randall, the Director of Finance. Sorry, this is a new title for me.
I can say it.
All right, thank you.
All right.
I know your name.
Good afternoon, everyone. Thank you. My name is Mike Randall, as she said. I'm the Director of the Division of Healthcare Finance and also the State Medicaid Director. What I'm going to do is go through a brief presentation. I'm also going to introduce the questions as we move through the process, as Dr. Mosier had indicated, with the information that we're going to share today. So these renewal meetings really are, we want to get your feedback on KanCare 2.0. That's why we're having these. We have meetings set up across the state, really through the remainder of this month. We have 6 different cities twice a day that we'll be doing these meetings. After we gather the information for this set of meetings, we're also going to have meetings after we've kind of posted the information in the fall so we can go through this process again. I don't know what the date is. This is going to be early or late fall of this year. It's going to be a multi-year renewal process. So as you probably know, we are in basically year 5 of our initial 1115 waiver demonstration. That right now ends December 31st, 2017. This renewal process will be for at least 5 years, and we are planning to submit that renewal at the end of this year, probably around the end of November of 2017. But as we said, the purpose of us being here and the purpose of us being in these other cities throughout the rest of this month is we want to get your input. We value that input. You are the members and the providers who have been giving us services for our members, and so we really value the information that you're going to share with us. This is probably going to be a very tough slide to read for you, so I'm going to step up here so I can read a little bit better, but this is really the multi-year renewal process. You can kind of go through, we're conducting these meetings May and June of 2017. We'll develop a draft renewal application throughout the summer. We'll post that application for review and public comment. That'll be, as I said, the fall of 2017. The renewal application will be submitted to CMS at the end of this year. CMS will have public notice and consultation with the state throughout 2018. And the final step in that process is that we'll come to an agreement with CMS, what we call our special terms and conditions, basically our contract with CMS on the new waiver, which will be effective 1/1 of 2019. KanCare extension, different than renewal. As I said earlier, our initial 1115 waiver demonstration expires December 31st of this year. We are working with CMS and we have submitted an application for an extension of the current waiver. This started in January 2013, the initial 5-year demonstration period. We have submitted that application. It will be a 1-year extension of our current 1115 waiver. And that will begin on January 1st of 2018. Now, we will also be having public meetings for that extension renewal as well. I think it's July 5th and 6th, or July 6th and 7th. We'll be having those meetings across the state. I don't think I'll read this through you completely, but it's very similar to what I just did with respect to the renewal process. So we've gathered the information, we're developing, we have submitted the renewal application for the extension request to CMS. We'll post that for public review. They'll be submitted to CMS July, August of this year. They'll have public notice, and then we'll come again, probably toward the end of September, October. We'll again go through special terms and conditions with CMS for the 1-year extension of our current waiver. Just a brief overview of the current KanCare program. Many of you have seen these slides before. One thing I want to emphasize too on the extension, and it may be in the slide coming up, is that the extension simply extends for a one-year period our current program. So there's no changes in services, there's no changing in population, it simply extends that date. That's all it does. Overview of KanCare currently, like I said, many of you have seen this before. We're in year 5 of our initial demonstration period. Kansas is really one of the only states. We have about 96% of our population in KanCare. We have approximately 400,000 members in KanCare right now. And Dr. Mosher alluded to kind of breaking down the silos of care, so we want that integration of care across our members, the whole continuum of healthcare. So we didn't want to carve out behavioral health or pharmacy or any other service. We wanted that 360-degree view of that member. Again, serves about 400,000 members, more than half are children in the KanCare program. About 25% are individuals with disabilities. We also have within the 1115 waiver authority the 1915C waivers, the HCBS waivers, so we have 7 of the HCBS waivers in managed care as well. I won't read this entire list to you, but these are the KanCare beneficiaries or population groups in which we provide services in KanCare in our Medicaid program. And as I said, more than half of our members are children. KanCare benefits for Kansas. One of the things within the managed care, what we were able to do is add new services. So we had weight loss surgery, heart and lung transplants were added with the 1115 waiver and the managed care. We also have something that they call value-added services. And between the 3 MCOs to date, they've provided more than $18 million worth of those value-added services to our members. Dr. Mosher alluded to this, spoke about this. These are the 3 topics that we're going to come talk about today with respect to what we're focusing on KanCare 2.0 and the renewal process. Value-based purchasing, administrative streamlining, and we're going to talk a little bit about training, effectiveness, and the needs of our providers. Value-based purchasing, I won't read the slides to you. Basically, it's really paying for quality outcomes, some type of quality health outcome, versus in traditional fee-for-service, you're simply paying for that service. This is going to be tied to some type of outcome where an incentive potentially could be paid as well. It really holds the healthcare provider accountable for the care for the members, and it really attempts to remove what could be an inappropriate care within a fee-for-service delivery model. Medicare and most private insurers are now including more value-based purchasing in their contracts. And you can see it's incentives, bonuses for improved health outcomes. It could be episodic or bundled payments, shared savings. If you achieve certain health outcomes for the population, you get shared savings from the provider or from the health insurance companies. It could be population-based care, so maybe you want to focus on one target population and have some type of alternative payment model, value-based purchasing with respect to that one population. Questions to consider with respect to value-based purchasing. Just held that a little too close, didn't I? Sorry about that. What outcomes should we focus on? What experiences have you had with value-based purchasing so far? How did it work for you? Did it work or did it not work? And what opportunities do you see in value-based purchasing from your perspective? So those are the questions we'll focus on. And what I'm going to do now is I'm going to turn it back over to Jen so we can focus on those questions and get your input.
Thank you. So how we would like to work this is we will move from table to table. So Steph and Lindsay will be moving from table to table, and basically we would like to, at each table, take any, for this topic that we just covered, take any feedback, comments, questions, ideas at each table, anyone that has feedback, and then move on to the next. So does that sound fair?
And if you want the microphone to come to you, please be at a numbered table. And if you need some help finding a spot at a numbered table, Bill would be happy to help get you placed.
So in regards to the value-based purchasing, it says that it's linking the payment to increased outcomes. So is there going to be more scrutiny placed if an individual, say an IDD service, is not increasing their independence, then we're not going to get paid for that individual, even if there's those factors that are keeping them from increasing independence?
I think what we will do as a state, the state Medicaid agency, is we'll work with you, the providers and others. What outcomes do we want? What are those quality outcomes that we want to see for those populations? Obviously, we want to make sure that you can effectuate that change, right? So if it's something that you really have no impact and you can't effectuate change, then we're not going to hold you accountable for that. But we want to work with you and other providers and what makes sense as far as those quality outcomes.
So my question kind of goes along with that. Who's going to determine those outcomes and what that criteria is going to be to whether or not they've been met or not?
Well, what we'll do, and we have some value-based purchasing or alternative payment models in place right now. The MCOs have always been allowed to have some type of incentive or shared savings within this program, and we have some of that. Right now we have with primary care physicians and some of the community mental health centers have some shared savings arrangements in place. But to specifically answer your question, we're going to work with you, the providers, the advocacy groups, to really define what makes sense. And it may not be the same for each population, right? It could be something different for the waivers. It could be something different for women and children on an acute care side. I don't know, but we will work with you to define what those are, and then the state will ultimately approve any value-based purchasing arrangement or contractual arrangement with the MCOs, and they'll monitor, as well as the state will have oversight of whether those measures were met or not met.
Thank you. I'm Richard Gilchrist from Mirror Incorporated. One of the things that we just that we know that capacity is insufficient, and those access to care limits are, of course, they affect outcomes. And we think that with increased capacity and better access to care, that would further increase the outcomes. And so I was wondering, are there measures that may be looked at in monitoring the outcomes for the value-based? Are there any things that we can do different to help us increase our outcomes with respect to access to care and improving capacity?
Well, I think a couple of things. I think right now, even the current contract with the MCOs, there's network adequacy requirements that we have for each of the 3 MCOs. We monitor that with respect to network adequacy by provider type. So that goes to your access or capacity concerns. I think also there are other measures that we'll put in place to ensure that those measures are met. And like I said before, we'll work with you to define what those are. The state is not going to say, because we're not the subject matter experts. We'll work with KDHE, we'll work with KDAS, we'll work with providers, what makes sense for those populations. And we'll specifically, from my perspective as Medicaid director, one of the concerns I have is from an HCBS provider perspective is some access or capacity. So how do we measure that? How do we ensure that those members are getting those services? So one of the things you look at is, okay, here was a plan of care that was developed, right, and it was submitted. So when was the first service provided? So that might be an indication. If it was provided within 7 days, 10 days, or whatever, might not have an access or concern. But if it was 60 days or more, then we have a question that we need to get answered. Right, so the next topic then, we're going to look at what experiences have you had with value-based purchasing, and then how did it work? Did it work well for you? Was it a total disaster? If it was, why do you think it was? And I'm going to alter that, because I can. Is in the sense that you've not had the experience of value-based purchasing, and you really want to, how do you feel it would work for you as a provider? What would you want to see specifically? Because I know a lot of you probably have not had value-based purchasing arrangements or some type of alternative payment model. So what would you want to see? What would work well for you if you were to go down that path?
We've had some experience at a community mental health center setting, working with MCOs around working towards improving outcomes in groups of individuals that would fit into mental health target population around certain healthcare and HEDIS measures. In fact, we've been able to implement 3 different plans, projects, each with the MCOs. In one of those, in terms of a benefit to our consumers, we are seeing improvements in outcomes related to A1C levels being monitored, access to primary care, follow-up post-hospitalization, even though it's hard to measure at this point, even having an impact on ER visit reduction, those kinds of areas. In terms of benefit to the agency itself financially, we've actually experienced our first payment from them in regard to that, and even though it's early in the process, felt like we did well with that. Heard from a few other mental health centers about that experience being positive. The value of the health home program that was discontinued last year was that it gave us a really intensive taste of some of those activities that the MCOs then were able to continue with these particular pilot projects. And some centers were able to benefit from taking advantage of staff who remained within our agencies from the health home program and were able to be retained. And because of the knowledge with the health home program and its population kind of health-based approach, we were able to benefit from that. I think one of the things that's a bit of a challenge is from a staffing point of view, because we operate in many ways in a fee-for-service, and the incentive payments follow the activities because of the delay in measuring the HEDIS activities. And so you have to have money ahead of that in order to sustain those activities to get a benefit later. But it gives us an opportunity to begin to get our feet wet. And so it has a number of positives, and the fact that we can begin that without essentially without risk, but with benefits, the way that they've been able to set that up initially as an opportunity to try it out has been positive as well.
Appreciate those comments very much. I know that we work with community mental health centers, as did the MCOs, to put those arrangements in place. And he stated one thing, I want to make sure everyone understands that too. He talked about no risk. For those of you that understand value-based purchasing, shared savings, all the arrangements that we have in place right now, there is no risk. So it's all upside. So at this point, we've not approved any arrangements where there would be risk. At some point, would we? Potentially. But then the state would look at the individual provider and see if they would be able to potentially have that risk. I would be thinking primarily of a large primary care physician group, or maybe a large hospital who could really manage that risk and has the staff in which to do that.
Yeah, the only thing that I had that was kind of close to that was experience with the pay-for-performance with the VR system. And one of the things that did was it only paid for the outcomes, so the positive outcomes, which is a good thing. But there's also reasons why some people don't get to those outcomes, and so there were costs in that you could never get reimbursed for. And a lot of the providers around the state stopped providing the service because they couldn't figure out how to make that part work. So it actually cost a lot of capacity in that, and I think it's one of the things that set us back in employment in the state. And if you look at some of the other systems that have done this, I think there's a process to get there that can make it positive. It's just how long does it take you to get there? Because like the Social Security Administration with the Ticket to Work program, I mean, they tried that, probably 10, 15 years before they actually figured out how to make the Ticket to Work actually work. And one of the things was they just couldn't get the incentives tied with the cost.
I think 2 comments. Number one is I think the upside, it would be beneficial because that, you would still be getting reimbursed the fee schedule or whatever the potential reimbursement would be. So you had that upside potential with those quality outcomes. If you were to introduce risk, I would agree with you that there might be some concern, but at this point it's just all upside. And secondly, you're right, we don't want to create any type of perverse incentives within this system, right? We want to make sure, that's why it's going to be very important that we work with you and others to develop those outcomes. Because certainly we don't want to set you up for failure. We want to set the bar high enough, right? But we don't want to make it impossible.
One of the things in looking forward to risk-based And as the Mental Health Center Association looks at that, part of what we are looking at doing is what does it cost each agency to deliver care, and to be able to be effective in evaluating that, and then being able to evaluate and determine the amount of care that we believe is appropriate based upon the level of severity of symptoms or presenting problems. And as we look forward to those risk-based activities around value-based purchasing, it will be important in negotiations around what the rate or the amount to be paid in the bundle payments, etc., so that providers have an opportunity not only to just break even, to be able to have enough so that they can improve or to build in terms of new things that come along or to advance. And so it would be critical for, as MCOs and the state look at that in terms of how the contracting will occur, how is that taken into account? Because and I know you've said this, Mike, but we have to be able to provide opportunities for growing, or because if you just stay the same, you don't get any better.
No, I agree, and I think that when we go through this process, one thing that I believe that we as Kansas have done very well, a lot of things we've done well in KanCare and the Medicaid program, but one of the things from an administrative type perspective is we kind of let the MCOs kind of work with the providers and negotiate those contracts. What was best for the providers and for the MCOs? Did we step in on a few of them? Yeah, we did, when there couldn't be an agreement, but we let that process take place. And we'll probably continue to let that process when you introduce risk again, because you as a provider know better than me as a state what you're willing to risk, right? And with risk, there's more potential. But you're exactly right. We will still approve and review all of those contracts, that any type of value-based purchasing.
Something I would like to be considered in this with possibilities is that what is considered valuable is clearly defined before it's implemented. Because if there's not that clear definition, then first people are flying blind. But then after they figure out, well, this worked and that didn't, then human nature is to focus on what's going to be approved. So if you're limiting that what's valuable to your one experience of what worked, we're probably missing a lot of other really valuable things and may reduce the value of the services to limited things for the clients.
Absolutely agree. So what opportunities do you see in value-based purchasing? Now we're going to kind of change a little bit here again. So what we'd like you to do, based on a recommendation, is let's take a few minutes in your table, or at your table. If you're by yourself, kind of move over to another table and just kind of discuss the question, and then hopefully that will generate some more questions or comments. Sometimes it's easier for you to talk as a group at your table, and then one person kind of be the designated speaker. So let's take a few minutes to do that, and we'll call you back in about 5 minutes. Okay? Thank you. Any comments, questions?
Well, actually, one is just to reconfirm what you said earlier to make sure I understood it, that the MCOs are going to be the ones that set the incentive rates and all of that, and not necessarily the state?
The MCOs will negotiate with the providers based on the individual contracts that they have with providers. The state will still approve all of those arrangements. We've done that for 5 years. Because I said, the provider and the MCO, you're the expert on what you can as far as risk and what you think you can do. So we will let the MCOs work with you, negotiate those. There probably will be guardrails in place as far as what those quality outcomes are. That's, as I alluded to earlier, we want to work with you to kind of define what those are.
Okay, that's what I thought. And then second, right now we only have the MCOs working with 2 of our health centers. They're our 2 biggest, and the smaller clinics kind of get left behind because they're not bringing as many people and patients and all of that. Is there a way you can direct and steer or advise the MCOs to look beyond the big money makers?
I can certainly, suggest that they consider other providers. I mean, they're sitting here, so I just asked them to consider so that I know they heard that. I think that what I've asked him to do in several meetings I've had with him is I want to make sure that the providers, not to say they're not sophisticated enough, but I want to make sure the providers really understand what they're getting into and what the commitment is. And sometimes the smaller providers, they simply don't have the staff nor the expertise or the bench strength to, get into an arrangement such as the value-based purchasing. But if they can and they're willing to do it, then I would encourage the MCOs to have those discussions. So, if you have specific ones that you would like, have them reach out to the MCOs and provider relations folks.
So, to follow up with her, does a provider then have the option to not be involved in the value-based purchasing? Am I hearing you say that?
I think what we're looking at is, and I don't think a decision's been made, as far as you talk about mandating that all providers participate. I don't know at this point. Like I said, we still have to have internal discussions, leadership to really understand. I don't think we would want to move down and mandated that all providers must. What we might look at is, because we feel there's value in having this type of arrangement for our members, because we're driving better health outcomes, and it's really better for the providers, and hold them accountable and so on and so forth. We may ask that a certain percentage of the population be under some sort of value-based purchasing or alternative payment model. So for example, I know Medicare has done this, right? By a certain time, they want 50% or 60% or whatever the percentage is of those members under some type of value-based purchasing or alternative payment model. That's something we might consider, but we haven't made that determination.
Okay, I just want to address a couple of issues as far as the opportunity for that. That may be a way of addressing some of the disincentives in the system whenever a provider gets someone a job, and then that's someone that they cannot longer bill for because of the system that's set up that way. And so now they have one less person to bill in their system, and they've actually done the right thing. So if we could incentivize that, and then the other piece of that I want to make sure we're clear on is that person's need for ongoing support doesn't really go away, it just changes. And the model of that changes, and so we need to be able to address that in some way as we figure out how to fund that in creative ways.
Absolutely, and I think one of the things that's really exciting about KanCare 2.0, and as we move forward with this, Dr. Mosier mentioned it, is how do we introduce social determinants into this, right? Because we all know the impact that has on a person's health. So that's one thing that we'll make sure that we are very careful as we move forward with that. But you're absolutely right.
I have one thing that I just want a little bit of clarification on, and then a question. So in the beginning I asked if providers are not going to get paid for a service based on it being determined it's not valuable, and you kind of said that you would work with us, but then you're also saying that there's no risk involved and that they're going to get paid no matter what, and any payment for value-based is on top. So I just want clarification on that.
Okay, let me give you the clarification. So let's say there's a certain procedure code that you provide a service, and it's a Medicaid allowable service.
Okay.
We're not going to take and say, if you didn't hit a value or a health outcome and you provide that service, I'm not going to say I'm not giving you that fee. So you'll still be reimbursed for providing that service. With a value-based purchasing arrangement or some type of alternative payment model, whatever those health outcomes are, that value, that's above and beyond. That's all upside. That's why we've not introduced risk into that. All right, so you would be getting your standard fee with respect to whatever allowable service you provided. It's just that any value-based purchasing arrangement you have in place would be on top of that, as you said.
Okay. And we're just curious to know if any IDD providers are currently utilizing any value-based services.
No, not that I'm aware of. And I'm the one that approves them all.
Okay. And they're available currently?
The MCOs have always been able to have some type of value-based purchasing arrangement with providers. If we'll go back, just allow me to go back just for a moment. In our contract, our original RFP, you'll recall that we mandated that when you negotiate contracts with the providers, MCO, at minimum you must pay the fee-for-service rate. You can go above the fee-for-service, but we also stated that with the agreement of the provider, you can go below that, for example. Let's go 97% of the fee-for-service, but then there has to be some type of value-based purchasing arrangement in place that gives that provider the opportunity to make at least the fee-for-service. So yes, they have the ability right now to have some type of arrangement.
And the selection of services that would be a part of value-based purchasing versus ones that would not be, do you see or look that some services would be in that area of value-based and maybe some still remain in the fee-for-service realm?
And I want to, well, I don't know. I mean, and I say that because I think that any service that's provided has the opportunity probably to have an impact on that outcome and the health outcome of the individual. So unless we got into some type of episodic or bundle payment or look at target populations and the services that are provided for those individuals, we would certainly look at that. But I think we would have to be very careful of really defining this particular service would have an impact on the value and health outcome, but this one wouldn't.
Maybe I could approach that differently in terms of looking at groups of...
So you mean I didn't answer your question, did I? That's okay. Go
I didn't get the answer I wanted, so...
Okay. Oh, you're trying again. I got you. I got you. I do that too. I do that too.
All right. Another way to look at this would be with groups of individuals who are receiving services, that the types of services that are likely to have an impact in a health area for a certain group of individuals might be more likely to be provided or contracted in value-based versus not. For example, in the mental health world, there are target populations of individuals that need intensive services, and they're identified by state criteria based upon the things that are met. And my expectation or thought is that those individuals and the needs that they have and the services they receive are more likely to be addressed through value-based purchasing because it provides an incentive to improve the quality of care and the delivery methods so that we're more efficient. Whereas someone who's not in that target group but still needs episodic or periodic or isolated care may not be as important to do value-based because it's limited to a point that it does not represent the kind of costs that need to be managed in such a way.
You may not like this answer either, but I understand what you're saying. But here's how I would probably approach it. We can certainly have the discussion, but I think I would focus on the correct value and the outcomes that we want for that population. Make sure we define that very carefully. And I think that then will drive the services that would be included within that. So not just really limited to the service, but let's define the quality and the outcome for that target population. And you know that you're going to provide these services to get to that outcome.
I think I like part of the answer.
Well, that's two. I'm getting there.
Well, part of what I heard in that is that you really didn't address those services that might be rendered to persons outside of that specific group. So I think what I heard you speak to, Mike, was specifically to persons in the target group, most specifically in what is desired to be accomplished for those individuals in their health care.
Correct. But like I said, we could have those other discussions. And I think one thing that we'll really focus on too with value-based purchasing and driving health outcomes is, as I mentioned earlier, we want that 360-degree view of the individual, managed care, integrated, and coordination of the care, and all those things that we want to see in managed care. But we also want to make sure we have accountability across behavioral health, physical health. So, having those particular providers, potentially, because you could have a behavioral health provider who could have an impact on physical health, right?
Microphone went away, but I don't always need a microphone. If you don't mind me asking a follow-up.
You go ahead.
Okay. I think you led into the area that I began to think about as well, and that is the integration of the various realms of healthcare. And you may, as the Medicaid authority, believe that really all that responsibility, or a lot of it, rests within the managed care organization. But the issue of how the state's going to continue to move us towards integrated health care, the comments and the research that I hear about indicate that in terms of physical health, taking care of behavioral health needs is critical. And any primary care doctor that I talk to will frequently go to that as an important piece of reducing the cost within primary health care by taking care of mental health needs well. And so my agency is within a rural area that's sparsely populated. But being able to find ways to effectively integrate, and that has multiple definitions, behavioral health into the primary care will be something that will be a really important thing to figure out, not only for high-density population areas, but also for those of us
Rural areas.
who live in rural areas. And I'm not talking necessarily about frontier, that's another matter. But that will be an important part of the conversation. I'm interested in figuring out how to do that in a way that it works for both the primary care as well as the behavioral health provider and provides that level of integration for the customer.
And we totally agree. I think integration is extremely important. And we'll be happy to work with you and others as we move forward with that. Other comments, questions? I'm sorry, you're right there.
Hello, I'm Jolene Walters. I'm the director of the Kickapoo Nation Health Center, and I'd like to just mimic what David just said. And for a community such as ours, IHS services have been providing integrated health care for a very long time. I am new to Kansas and the Kickapoo tribe relatively, but in other tribal areas, integrated health care is very easy. It's the goal, it's the standard. However, in the state of Kansas, I am running into more obstacles. And what I'm going to ask of you today is for more assistance. Someone who can work hands-on with the tribe to understand what we are going through. I was the mental health authority for the state of Oregon. I have a pretty good understanding how integrated healthcare works. So I just need some partners from the state. That's all I'm asking for.
We'll be happy to. So you can go to kancare.gov or the Division of Healthcare Finance, and my name and phone number's right there. You can certainly call that number and someone would be happy to work with you and we can set something up and we can have a discussion.
All right.
All right, we're going to move on to the next topic.
Well, I'm sorry, Mike, I do have one more person.
Oh, I'm sorry.
And we'll just remind the room, there will be an open comment round at the end, so if you didn't get a question or a comment in on this topic, there will be another chance.
So my question is, I mean, I don't know much about this value-added stuff or value-based purchasing stuff, but is there a way that that can work to help incentivize the MCOs to coordinate more with centers with independent living to help integrate people from institutions back into the community and their own homes?
I think from the quick answer is yes. How we define that would have to be determined, but yeah, anything could be possible with that. You could also, from an MCO perspective, look at some other opportunities from a pay-for-performance and some types of those outcomes too. But typically a value-based purchasing arrangement is between the provider and the MCO, but certainly you could gear and kind of arrange something and develop so you can have that specific impact. So that's very good feedback. Okay, now we're going to move to the next set of questions. After I tell you what it is, administrative streamlining. You know, with Kansas, we opted to contract with 3 MCOs to provide the services to our members, and we did that primarily to allow for consumer choice. You know, if at one MCO, there's really no choice, and CMS was very adamant about having appropriate choice in the managed care program for Kansas. You know, as many of you are aware, I don't have to tell you, their process is different. Some of them are the same, but a lot of them are different. So you're dealing with 3 different MCOs and 3 different processes. But we want to make sure we can strike a balance between the administrative burden and ease and innovation. So over the last 5 years though, and many of you may have heard about the Lieutenant Governor's Process Improvement Working Group, you know, I think we've done some really great things with the providers and the advocates and working with them and streamlining some of these processes and coming up with some standard prior authorizations, taking and removing those, some standard credentialing forms that we've been able to work with. So, but we want to move forward with that too. So questions to consider. And here's what I'm going to do. I don't want to go through each one of these one by one. So please look at all 3 questions. And then what we'll do is we'll, at your table, discuss the 3 questions, comments that you may have as well. Take about 10 minutes or so. And if you need more time, we'll look at more time. Then we'll bring you back and we'll start having discussion relative to these 3 questions. Thank you. Questions, comments? I see a hand right here.
Well, Mike, we have something up here up front, and then I'll move back.
All right.
Okay, so what is the first one? Oh, yeah, so one thing that we were talking about that would be great if it could be standardized across the MCOs is, you know, the federal money follows the person program is going away, so it's kind of going to be up to the MCOs to decide how they're going to fill that void, and it'd be great if we could come up with some kind of policy that would be across all the MCOs that was uniform, that would kind of preserve the funding and everything for that program, because it's really pretty critical helping people reintegrate.
We've actually had that very discussion internally, so thank you for those comments.
Hello, Mike. Thanks for the opportunity today. One of the things that we hear from our members, physician members, is typically billing issues. And I think a lot of this stems from policy interpretation, the way policy is written. There might be a policy in a bulletin, but it's not in the manual. MCOs are interpreting it 3 different ways. I think anything we can do to kind of streamline that would be cost saving for everyone. The MCOs wouldn't have to retouch things if we had more lead time on policies. In practices wouldn't have to retouch claims and refile them. I think anything we can do to kind of move towards that, and I understand that there's some talk about working on the KMAC manuals, but I think the sooner and better we can get that done, the better it's going to be for at least our physician members.
No, I appreciate those comments, and you're right. We have set a priority for the KMAT manuals, but it's a very, very comprehensive, complicated job that needs to be accomplished, and so it's really a priority. But it is important for us, and we are moving toward that.
Someone with when you have a new employee trying to figure out how this all works. So just have the same manual, and then if United Healthcare wants to do this, and you just have the exceptions, it would make everyone on the training side much easier. And that's just a tagline what you had to say. In terms of what is working, let's move on to something I'm very grateful for. We are now going to have a representative from the Scion side for United Healthcare and Amerigroup, and for 4.5 years we never had anyone to help advocate for us. So I'm very, very thrilled that the MCO is going to do that for us. Sunflower's done that from the beginning, and it has been extremely helpful. The other thing that would be helpful is if on all sides for time and resources, I don't know who or how these claims are read, but it would be really nice if they would read the entire claim, all of the narrative, and look at the documents before they just deny it. And then we have to reprocess this claim with all the exact same information, sometimes 3 times. That's not good on either side. It's one of the reasons providers get out. Another idea I think that would help streamline things is if the history could be shared more easily and faster. So they switch from one, they have a choice. So
are you talking about members switching from one to the other?
Members go from one to the other, and then it takes too long to get the history. So we end up duplicating services, and then we don't get paid because they already had that done. And we don't know they had that done because it's not on the history. So if they could streamline that, or honestly, I don't know how they'll fix that, but
question can be asked, right?
Right. So those are all my comments on this topic.
Well, great. Thank you very much. I appreciate it.
Hi, my name is Debbie. We do pediatric physical speech occupational therapy, mainly for children with disabilities, and we also do ABA services. So our questions are geared toward that. Pre-auth for PTOT and speech is completely different for each MCO. One doesn't require it, one now allows us 24 visits, and another one just flat out requires it, so we'd like to see that streamlined. And the forms are all different, which you learn to work with, but you're talking about streamlining, that would be nice. Credentialing is a nightmare. It is not standardized. Every MCO is different. Even within the MCO, there's differences because the behavioral health side for ABA is completely different from the health side. Do you have any comments on either of those before I continue?
Well, yeah, now, for prior authorization, as I said earlier, we're going through that process improvement working group with the Lieutenant Governor, and we've already identified numerous procedures that won't have prior auths again. So, and what our direction has been to the MCOs, and this should be coming out very soon because we have an update with the meeting tomorrow. I believe there's more than 53 that have been removed. But it's going to be standard across all 3 MCOs. That was our direction. I'm not going to have one MCO that says, okay, these 20 codes now, no more prior authorization, but then the other MCO has to have it. So our direction to them was, take a look at all of your prior authorizations and come back and give us recommendations on what we can remove. And so that's what they've done. And I think they've done a good job of that. With respect to credentialing, I can't speak specifically about ABA, but I do know that we have been working for a very long time on a common credentialing form. That should be standard. Now the process, we're moving towards standardized process, and that's going to be much easier once we get our new Kansas modular Medicaid information system online. Because then what the providers will do simply is they'll just basically go into that system, here's all my documentation, and the MCOs come down and just pull it out. So you're not sending it to this MCO and this MCO and this MCO.
So are you saying, because right now we have to get a KMAP provider number.
Right.
So we have to be credentialed by KMAP.
That's not going to change.
That's not going away.
But it's not going to, and even now with the new, have you heard of the new mega rule, the new managed care rule? It's something that CMS, promulgated, and it went into effect last July. Part of that rule, I think it was 1,400 pages, to give you some sense of context. Every provider who provides Medicaid services must have a common one Medicaid number, so that's not going to change.
Okay, but then there will be, because currently we have what's called CAQH, you're probably familiar with that they draw their information from. So there's going to be yet another format similar to CAQH that's going to be run by the state that they'll draw their information from?
It's called the Provider Enrollment Module. It's part of our Kansas Modular Medicaid Information System. I won't go into a lot of detail, but there's basically 8 different modules. One of them is provider enrollment. And so a very important thing for us is to standardize as many processes as we can. And I'm not going to stand here and tell you that we're going to standardize every process. That's just not going to happen. You can't. Right. It would be unreasonable to have MCOs and have that expectation. But we're doing the best we can to ensure that balance between administrative burden. So we're working toward that.
Okay. And one other point we had was about streamlining information release, especially in a more timely manner. A prime example of this are the recent autism waiver changes. We had one MCO jump the gun and created a nightmare for us. And then the state turned around at the 11th hour and implemented the changes retroactive to January 1. And it was like within 24 hours, the changes were being made. It was March 30th with changes being made April 1. The state did not communicate anything to providers of what was going on. Everything we heard was hearsay from the MCOs. The MCOs have guidelines that the providers have not been given from the state. So that's just a prime example of something that we would appreciate being streamlined.
Right, and then just a quick comment. We know that the communication to the provider network is extremely important. And what we've done from this working group as well, that was one of the issues that was identified. We now have one standard bulletin that goes out. So you're not going to get a bulletin from United, Sunflower, Ameriguru. The logos are basically on this one standard bulletin form. So that when you get that, the 3 MCOs are aware of it, KDHE, KDADS, we're all aware of it. So that's one of the things we've done. But we're still working on additional communication, not just across KDHE, but with KDADS and other entities as well, so that we know you get bombarded with communication. And so it's really a balance of effectively communicating. We have to be more effective at that.
I appreciate that. I mentioned that, consistent, plain language as you communicate with individuals and families. The more consistent we can be with that so people actually understand whenever they get a letter, they need to take action. I continually hear from people that, their brother or somebody got this letter and they didn't know what it was or didn't understand it, and then they get dropped from services, those kinds of things. And then the other thing we'd really like to see is a very standardized process in the person-centered planning with something like the life course tools that was developed by families for families, and that the system adapt to the family's needs, not the family always having to adapt to the changes that are happening with whoever you happen to be working with as you go through your different life courses and different stages of life.
Appreciate those comments. I want to keep us moving so we ensure we get to the third topic. So about another minute and a half. So maybe time for one more question.
All right, I'm here in the back, please.
Thank you very much. I'll take it. I'll hold it. I'm a senior citizen, been on this earth 70 plus years. I think fee-for-service is widely misunderstood. I have had outstanding care over those 70 years under fee-for-service, including care for several cancers, etc. I also spent 23 years as a mental health professional taking care of patients at the Menninger Clinic here in Topeka. And I watched them go through a painful process of deciding to close shop in Topeka and move to Houston. As I understand the last 30, 40 years of healthcare, the main change that has brought us almost to this crisis point in healthcare, insurance companies used to do what insurance companies do best. They collect premiums, they receive claims from doctors, and they simply pay the claim. The problem began when 30 years ago, insurance companies began to also manage care. Now, I would encourage you and the good folks in your area to rethink the whole model, since we're at a choice point of what to do. There is traditional Medicare, which is pretty much more like a traditional indemnity plan, where patient is seen by the doctor submits the claim, and the claim is paid. I'm not talking about Medicare Advantage, which is a different kettle of fish. So I know I'm in the minority. I doubt what I'm going to say is going to have a significant impact, but I encourage you to maintain an open mind and a vision about the future of Medicaid in Kansas, and maybe going back to the era and the way that Medicaid operated before managed care was introduced into the paradigm. Thank you.
You're very welcome. Thank you for your comments. I appreciate that. We're going to move on to the last topic. Training effectiveness and needs. Right now, in the current MCO contract, we require them to provide training every quarter. I attended one in May in Wichita. I thought it was very well attended by providers. It was very well put on. The agenda was great. So that will continue, and we get feedback from the providers on what they want to be trained on. So that's what we're kind of asking for here as well. The trainings are in person, they have webinars, there's conference calls, but we're looking at, for example, claims, billing issues, grievance and appeals. So it's very, very, very detailed. The one I sat through, I would say about 75% of what was discussed just went right over here. CPT codes, very specific, and HIPAA, all those kind of things that you people know about. The new contracts will begin January 1st of 2019, so I guess my question is, we're going to kind of take a look at these. Does the MCO training work for you? Do we do it differently? Do we continue to require quarterly training? If there's a new MCO, there could be one or two new MCOs, we don't know. What specific training may you need as providers from that new MCO? Because they'll be coming into the Kansas marketplace with no history. So think about those two questions and take about 7 minutes. Not 8, 7 minutes. All right, thank you. All right, let me ask this question while you're considering questions or comments. How many of you have attended one of these MCO training sessions? Raise your hand. So not that many, but did you find them valuable? Okay.
All right, Mike, I have a comment over here, and I'm on your left.
My left, my
Your
military left.
All right, thank you. We would like to see more specialized training for different, based on a provider type. You sit through a training session and there's information about hospitals. I don't deal with hospitals, but we would just keep it short. We would like to see specialized. And I know we went to an all MCO training and we really appreciated the breakout rooms and being able
That's just what I was thinking. I think probably because from a scheduling perspective, you might just have breakout sessions by provider.
That's kind of my thought too on that. But the breakout rooms were very helpful. It was nice to be able to put a face to a name and network with your provider representatives. Thank you.
You're welcome. Thank you. Hi, Ruth.
Hello, Mike. So the first question, does the MCO training work for you? Yes, it does. I think a large number of our members send staff to these meetings. And these meetings are so important because there's often high turnover in practices.
Absolutely.
You know, so this is a very complex program, so I think the more training we can have, the more detailed information we can have, the better. One of the things that I think would be helpful is to have some recorded education available, maybe from the MCO's websites on certain aspects, and I think some of them do that already. The second question, if there's a new MCO, what training would you need prior to and immediately after? My concern is prior to, who's training the MCO? And then it gets back into the policy piece and that interpretation stuff. So that would play in. And then what do we do with the exiting MCO? Let's say you're 6 months out on claim appeals and they've left town, and what are those processes going to be like? What's the continuity of care issues? You know, let's say you've got patients displaced in plans with physicians who aren't on that plan, and is there going to be a time frame that we can, you know, work through all those issues? So those are the kind of things that I think.
Great comments, appreciate that. And we do have transition plans in place. And our goal is to award early enough to have that 6 month time frame. All right, so we just want to kind of roll into general comments or general questions? So I'm going to, because I'm anal retentive, I'm going to have to walk through this, make sure I get through this presentation or it'll drive me crazy. So any comment, any question that you may have. So not topic specific, so this is your opportunity.
All right. Mike, we're going to be over here on your left tabletop.
My left. Hi. I don't care. Hi, my name's Stuart Little, and I'm here representing a variety of folks who do providers around the state that do substance use disorder treatment, working with younger kids, touching the foster care system, which I think is something that needs to be mentioned as part of this. And these folks that I'm representing are interested in going through the process of KanCare Renewal to be making changes in the behavioral health care system and doing the system in a new way, talking about providing greater access to care, providing, expanding the capacity in the system for behavioral health, and making sure that through the funding and the structure that you all establish in the KanCare 2.0 that you're accomplishing the Secretary's goals that she mentioned in the beginning in terms of integrating care, behavioral health as a component of that, and to make sure that those issues go into the RFP. I appreciate that. Thank you.
All right, thank you for those comments. And I will share one thing is from the foster care, that's something that we've discussed extensively internally, and that's something that we will be focusing on. It's very important for us as well.
So I have, I believe, 2 more at this table, if you don't mind.
I was kind of going back to the second questions a little bit too, but as the administrative streamlining is occurring in the IDD field, targeted case managers are being required to do more and more. However, it's all work that 3 to 4 years ago was deemed unbillable. And so it's basically more and more work that is causing extreme capacity issues. All case management agencies in the Shawnee County area have been closed for referrals at some point here recently, which is something new that's been seen since I've been in the field for 5 years, as well as the 4% cut that we took last year. So I think it needs to be relooked at what is going to be billable for targeted case managers, if it's going to be a requirement that they're doing all this work for the MCOs.
Thank you for those comments, and I will share with you the provider network, you probably already know, but the budget that was passed, and the governor hasn't signed it yet, however, it does restore the 4% cut.
So I'm going to piggyback off of what Stuart said a little bit, and then integration was brought up previously, so I'll piggyback off that too as well. In regards to integrated healthcare, behavioral health services, our clinics and health centers across the state are already pretty darn awesome at doing that right now. Patient comes in to see their primary health care provider, maybe to get a diabetes check, and say, I'm not really feeling very well, kind of depressed. The provider can track down the hall, get a behavioral health specialist in, see them, get care kind of going. So that process is working and going really well. However, right now we can't bill for those services. So having those HBAI codes, I think it's 96150 through 55, would be fantastic to get paid for the services that are already being provided.
Thank you.
Thank you.
All right, I'm back here at table 18.
Hi, my name is Angela, and I'm with St. Francis out of the Hayes, Kansas office. This is kind of a question that I have. We have children that are closing out of foster care and then returning to their family of origin or their biological family home, and we understand that when they do that, they'll reapply for their Medicaid product. And in doing so, we've discovered that we've had kids that have had gap in coverage. And the problem with that is that we have kids with medical problems or psychiatric stabilization. For instance, we had a child come in for stabilization of a psychiatric issue, then they stabilize, we send them home, and they have a gap in coverage, and they become unstabilized again, which is why they came into care in the first place. So I was just curious about these for example, I've had cases where I've called KanCare, and the coverage is approved. They've got the application that's been done since the child has returned home with the family. But then when I call the managed provider, it hasn't trickled down yet. KanCare says, well, it could be 24 to 48, but in certain instances, a week later, it still hasn't gone down the pike.
Yeah, and as I said to Stuart a few minutes ago, the foster care population is something we're going to focus on, especially at KanCare 2.0, but that's something we don't need to wait for KanCare 2.0. So we'll go back, and I have staff here that just heard that, and eligibility individuals here who just heard that. So I don't want a gap in coverage, because to your point, you have a foster care child that has those psychiatric or behavioral health needs. The last thing you need is for them to take 30 or 45 days or longer to get back on Medicaid. And then when they get back on Medicaid, they've destabilized, now you're back to square one. So we'll go back and kind of take a look at what that situation might be in the scenario and see if there's something that can be done differently. I don't know, but I'm going to rely on staff to do that for me.
And I'm moving here to table 17.
Okay, so I have a question.
Okay.
I have a lot of ideas that would help balance the budget financially.
Wow.
And I need to know how I can be heard for that. It's not that I'm trying to take money away from KanCare or take money away from the pile of money that we get from the state. I would just like to see us spend it more wisely. And I don't know how to, on the dental side, because I know nothing about the rest of it. Mm-hmm. But I think that there are some things that could really help our pile of money.
Well,
who do I talk to?
2 suggestions. You can send me the information. We'd be happy to review that and look at that. You always have the opportunity or ability to send it to your state legislator. So I'll let you, choose how you would like to proceed. But if I get information, I certainly do pass it along to staff, and we evaluate, and be happy to take a look at that and what your thoughts and ideas might be.
Okay, two other things. I didn't know anything about the first thing you all talked about, but I was...
Value-based purchasing?
Yes, I was informed that with that, HbA1c levels are one of the critical areas. Mm-hmm. That is very important to us in dentistry. And we have a difficult time getting the HbA1c level quickly. So since KanCare, the managed care organization, has that information, how can I access it without having to pay another service outside, like, you know, the Department of Health, in order to get that information? How can I do that? The patient doesn't seem to know when they had it, where they had it, who had it, who their doctor is.
This is clinical data, is it not, Ron?
How can I get that information?
We, let's take that offline, and then afterwards, I guess, we do have the MCOs here, because I honestly do not know. I mean, it's not encounter data or claims-based data, I know that. It's clinical data. And we have trouble getting that information as well, and we're trying to get some of that. So after the meeting, if you want to visit with one of the MCOs.
Third question.
Okay.
Third question. Other dental insurances have a method and a way of helping us with children of sexual abuse. In trying to report that through a managed care organization, there is no way to help that individual. And I want to know how we can change that.
I guess what I'd like to know, and we'll take time up here, is I'd like more specific information on exactly what you're asking, okay? So let's have a discussion after, because I need to understand that.
All right, Mike, I'm over here on your left, and I'm in the back row. So
I see you, yeah.
All right, we have one at table 13.
All right.
I was just going back to the area when you talked about communication as far as an outcome.
Right.
And that with the MCOs and the FMS providers and the individuals on the HCBS waivers, if we could have a better look at communication when we're trying to get services started for someone, as far as the timeline and also information with the individuals we seem to have care coordinators changing constantly, and people are not notified who their new care coordinator is, and neither are we as FMS providers. So it really slows down when we're trying to track down a new ISP or track down authorizations for someone, if we can have better communication on that. The other thing is, if we could work, maybe the MCOs and a group of people work together to do better at the ISPs themselves. We have one MCO that has a 42-page ISP, we have an 8-page, we have a 10-page. So if we could get those to be narrowed down and have the same information, it's very hard when families change MCOs trying to understand and read them.
Thank you for those comments.
All right, I'm here in the center of the room at table 16.
Hi, Mike, I'll be brief.
Hey, Janice, how are you?
Agencies on Aging. We would ask that long-term services and supports is elevated to the same level, if you will, as physical health and mental health, just in conversation, just in vernacular, just in day-to-day policy. From our perspective, we would love to see that individuals on the waivers, particularly those where a nursing facility is the institutional equivalent, that in Kansas we once again become one of the most progressive states in the nation to try to reduce nursing facility length of stays, and we really push hard for community-based services for seniors and folks with disabilities who want to stay in the community for as long as possible. It feels like we can get there again with 2.0, but I think it's going to take some deliberate conversation. We're glad to see the folks from KDADS here today to just make sure that LTSS stays on the table.
Thank you, Janice. Time for about maybe one more question. You go.
Okay. I had a consumer who wanted to change MCOs like October. She couldn't because she wasn't within the period to change MCOs and wouldn't be for 1 year. I think it should be easier for a person to change MCOs.
Thank you for those comments, and kind of what I think the concern was, there is annual enrollment, so once a year, but we do have good cause reasons for change with the MCOs too, but we can certainly go back and review what those good cause reasons are and see if it needs to be changed or updated.
Okay.
Thank you for the privilege to share a few comments. Since clearly you're going to continue with the managed care model, which is fine, let me share a brief story and then a recommendation. When I was with the Medicare Clinic in Topeka, they needed to enroll in managed care networks, and they needed a clinician, a volunteer, to go with some of the business people to get that process started. So over a 4-year period, I was able to visit 100 insurance companies and managed care companies across America. The main take-home message was all managed care companies are not alike. And based on 100 companies, I was able to create 4 groups of managed care companies. And I'll share both A and D. A, managed care understands that doctors know what they're doing and hospitals know how to treat patients. And they really, these A companies, type A companies, kind of stay on the sidelines of managing care. They also pay a reasonable and fair rate. Managed care makes its living through 3 main mechanisms: pre-authorization, concurrent review, and retroactive review. The type A companies do very little of that. Type D, on the other hand, engage in require considerable pre-authorization, do a lot of concurrent review, and do a lot of retroactive review. My wish for you and my dream for the Medicaid beneficiaries and the state of Kansas is that you screen carefully and understand the parameters and the ways and the psychology and the business philosophy of each of the companies who apply to be MCOs in Medicaid, and you choose mainly companies that are in that type A or top group. Thank you.
Thank you for your comments, we appreciate that. All right, so I'm going to finish just a couple of slides. I know I appreciate everyone's time and being here today. You know, it's 2 hours, sometimes it may not seem like enough time. You go home tonight, you get up tomorrow, next day, week, whatever the case might be. If you have additional comments or questions, you can email right here, kdhe.cancarerenewal@kes.gov, or if you like snail mail, you can snail mail to KanCare Renewal, care of Becky Ross, and you can see the address here. In a few days, the information that is shared here today will be available on the website, so you can see that information. I'm not quite sure what the plan is for this thing right here, but I imagine it's going to be put on the web at some point, so you can have that as well. The public hearings will happen this fall. Well, like I said before, what we're going to do is we will gather comments that we have through these 6 cities that we're going through the next 3.5 weeks. We'll draft the RFP and a proposal, we'll put that out. We'll get additional comments and we'll go out again, probably to the same 6 cities, I would imagine, and have these fall meetings and gather additional input on what was drafted and what was posted. And as always, you can check kancare.ks.gov for any updates relative to the renewal. And again, I appreciate your time. Everything that was said today I think was very valuable. We had some good dialogue and I appreciate that. So be safe, and we're going to be back here tonight at 6 o'clock and do this all over again. So again, thank you very much for your time, everyone.